Hi, my name is Mike Pishfine. I'm a GI medical oncologist at Johns Hopkins University, and it's my pleasure to be a moderator here for a GI oncology tumor board. And I'd like to go around and introduce the panel. I'll start with Dr. Zev Weinberg from UCLA.
Hi, my name is Dr. Zev Weinberg. I am a GI medical oncologist at UCLA, Los Angeles, California. Nice to be here.
And then from Emory, Dr. Pritesh Patel.
Hello, Pritesh Patel, Associate Professor of Radiation Oncology, GI Radiation Oncology at Emory.
From Memorial Sloan Kettering, Dr. Martin Weiser.
Hi, I'm Dr. Marty Weiser. I'm a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center.
And finally, from Washington University in St. Louis, Dr. Carrie Siegel.
Hello, my name is Carrie Siegel. I'm an abdominal radiologist at the Mallinckrodt Institute of Radiology at Washington University in St. Louis.
Well, thank you all for joining us. It's going to be some very interesting discussion about some exceptional cases, and I think we should go ahead and dive right into it. 38-year-old Caucasian woman with a history of heavy alcohol use presented with a Stage IIIA T1N1M0 rectal adenocarcinoma. She had preoperative chemoradiation with capecitabine, and then her treatment, unfortunately, was complicated by recurrent urinary tract infections, resulting in sepsis and hospitalization and worsening of her liver function. The liver biopsy did reveal underlying cirrhosis. A post-treatment proctoscopy showed the malignant appearing mass at 7 centimeters from the anal verge in the posterior midline, but the post-treatment pelvic MRI showed no evidence of residual disease. And the colorectal surgeon was concerned about the patient's cirrhosis and being a good surgical candidate. So first of all, we're going to talk about how to explain the discordance between the post-treatment proctoscopy and the pelvic MRI, the next best step for management of this patient, and then whether or not to proceed with additional systemic therapy. The patient presented with progressive left lower abdominal pain, bloating, and constipation. Initially, the ECOG performance status was 0, but it's steadily declined to 2. As mentioned, the patient does have a history of what's now being recognized as a developing cirrhosis. She's a former smoker, 10 pack years, quit in 2020, and a history of very heavy alcohol use. And she quit in July 2020, no recreational drug use, and no family history of cancer. In July 2020, the pelvic MRI showed hepatic steatosis as well as a 2.9 centimeter polypoid tumor in the mid to low rectum with a possible node in the left mesorectal fascia, as well as cysts in both adnexa measuring 7.2 centimeters. A CT chest abdomen pelvis showed enlargement of the right lobe of the liver and bilateral adnexal masses. The colonoscopy confirmed an invasive adenocarcinoma arising from a villus adenoma with high-grade dysplasia. The tumor is a grade 2 with invasive carcinoma at the cauterized edge tissue and microsatellite stable. Of note, the patient was seen by a gynecologic oncologist who felt that the adnexal masses were not related to the rectal cancer, and so the patient initiated curative intent preoperative chemoradiation with capecitabine, but as mentioned, unfortunately, her treatment was delayed due to admissions for sepsis from urinary tract infections. She completed chemoradiation in December 2020. In January 2021, the patient was rehospitalized for extended spectrum beta-lactamase resistant bacteremia. And unfortunately, at that time, the liver function tests showed a significant decline with a bilirubin of 11.4 and a mild elevation in the AST as well. The patient did get some improvement by the time of discharge, but the bilirubin was still 7. A liver biopsy was done in February of 2021 that showed developing cirrhosis related to underlying alcohol. And as mentioned, the proctoscopy showed a rectal mass 7 centimeters from the anal verge, but the MRI showed no residual disease. So, Dr. Siegel, here's the pelvic MRI from July 2020, and there's a couple, one additional image when you want me to move forward.
Let's pause here for a moment. You can see this is a pretty midline sagittal view. We see the symphysis pubis, the bladder, urethra, the uterus and the cervix, and a polypoid mass in the rectum, and that cystic lesion, bright on T2, cephalad to the bladder, is one of the ovarian lesions. Okay, and then if you move forward, here we can see a different sagittal view here, and then there's one cystic lesion again above the bladder. That's one of the cystic lesions, and then the more posterior one is another one. and the mass is not identified.
So, Dr. Siegel, what are your thoughts on the discordance between the proctoscopy and the MRI?
Well, occasionally there's discordance between imaging and colonoscopy, proctoscopy. I'm not an expert on when the colonoscopy could occasionally miss a mass that radiology picks up, but I will discuss the different things that can occur, how a radiologist could miss a mass. One of our most common problems is super redundant sigmoid colons. And as radiologists, we follow every single loop. And if it's super redundant, we could miss a loop that could have a polypoid mass in it. That's number one. Two, stool burden. Either it's imaged in such a way that we think it might be a tumor, or it's imaged in such a way that it's obscuring a tumor. Other options are very small tumors or very flat or carpet-like tumors. And then the last thing is mucinous tumors. We haven't discussed this much, but I've talked a lot during this session on how valuable diffusion is. But diffusion's not good in mucinous tumors. We can get very fooled. Other than that, the other areas where we can run into trouble are technical artifacts. Either there's patient motion on the scan, there's a clip causing an artifact right where we need to see the tumor, or more commonly in these patients, there's a hip prosthesis. So those are all the things that I could run into trouble with.
Gotcha.
Although I have to say 7 centimeters is pretty big to miss.
Dr. Weiser, I wanted to ask, we talked a little bit about what makes a patient a candidate for a non-operative therapy. And here we have a patient that is most likely medically inoperable. If there is a residual mass on proctoscopy, colonoscopy, but the biopsies are actually negative, how do you know that you're not just dealing with a treated and otherwise cured tumor and the sort of the scar remaining from it?
Yeah, I think that's the current biggest challenge with non-operative management. Now, after non-operative management or after TNT, there are those patients where you look in with the proctoscope and it looks like a flat white scar. Those are easy, but there are others where you could have some fibrosis or abnormality and you just don't know. Biopsy is usually not that helpful because you could easily miss it. You wouldn't trust it. There are occasions where we've asked our gastroenterologist to perform ESD or a dissection within the submucosal plane that will not jeopardize future surgery. That's the key, especially if you want to do sphincter preservation, to try to prove if there's disease there or not. I would argue, though, in the setting of a fit patient, if there's a remaining lesion there, surgery is still the answer. But in this case, often we may watch very closely over time to look for change. Regrowths will generally grow over time, and if there's a stable lesion, like in any cancer patient, we may watch it.
Gotcha. Dr. Patel, in this scenario, one can envision that the patient received chemoradiation. It ended in December 2020, and then thereafter, before surgery could be definitively planned, the decision was made that the patient was medically inoperable. Would you do anything different at that point to the radiation? Would there be any kind of enhancements to the radiation to make it more definitive radiation?
Good question. I think in this case, I think it looked like the radiation started several months prior to, when it ended. So that I worried that there was a long treatment break here, which certainly will reduce the efficacy of the treatment. But sort of speaking along the lines of non-operative management, I think there are some maybe some hypothesis generating data from the group from Brazil, where a slightly higher dose of radiation might be associated with a better chance at complete clinical response. So 54 gray as opposed to 50 gray, for example. Other small series that have looked at this has gone much higher with 60 gray of radiation plus brachytherapy, a European study which didn't really show a much higher rate. So and more toxicity. So you've got to be careful with going too high, but a modest escalation, as long as it's done all together, perhaps might increase the chance of a clinical complete response. This is a great question to ask in a clinical trial, which I hope will be activated at some point. But in this case, when there's been a long break, either during the radiation or thereafter, there's not much of a benefit of adding a little boost, for example, with a long break.
Gotcha. And Dr. Weinberg, the patient's gotten some systemic chemotherapy with the capecitabine concurrently with the radiation. Would you do anything differently now that there was a decision not to move forward with surgery, or would you just sort of watch and wait and treat with systemic therapy upon progression?
I would do the latter. I would not be too enthusiastic about treating this patient right now in the absence of active disease that's confirmed. I think their patient ideally should be a little more optimized from a hepatology perspective, and while the bilirubin improvement is a good sign, certainly before I would launch into new chemotherapy regimen, I'd want to have a more convincing picture that there is there's a need for systemic therapy.
Good, makes sense. All right, yeah. So I think the panel on this one definitely is in agreement that this patient does very much seem like a non-operative candidate, and so with the tumor just having had a nice response, but it may not be completely gone, there wouldn't really be any role for an additional boost of radiation, and just watching and waiting right now and not giving any chemotherapy would probably be the appropriate thing. And what systemic therapy the patient eventually receives is going to really depend upon the patient's hepatic function as the cirrhosis is being managed in the coming months.